Okay. Hi, everybody. I'm Jillian Bartlett. I'm the Executive Director of the Primary and Integrated Healthcare Innovations Network. I'll be moderating this learning series. Thank you for joining us. Today's topic is going to be long-haul COVID-19 and primary care. So talking a little bit about research priority setting and the experiences. I would like to thank our co-host for this particular session, which is PEI, the Primary and Integrated Healthcare Innovations Networks out of PEI. Today, we're going to hear from Sabrina Wong and David Barber for some scientific evidence. And then we have guest Tim McMurray with us to talk about his experience. And we are still waiting. We're hoping that Terry Matson can join us. So I'm going to explain a little bit about how the Zoom webinar works. And then I'll be reading a virtual land acknowledgement, and then I will turn it over to our speakers. After they give their talks, we will have a moderated question and answer session. So the thing that's different about a Zoom webinar is there are two ways to communicate with us. One is a chat, and if you use the chat, please use the chat for comments that you would like to share with everybody. If you have a question you would like the panelists to answer, you'll see there's a button on the bottom of your screen that says Q&A, and it's got two little chat icons together. If you click on that, you have the ability to type in your question, and you can do that either anonymously or with your name attached and post it. I will then see it, and I will read it out loud for the panelists to answer. The other reason I'm reading it out loud and we answer the questions live is because if a panelist answers the question directly, the rest of the webinar attendees won't see it. So you have two ways to communicate. You have the comments, and I believe if in your chat, you can either just communicate with us as panelists, or if you have a comment you want to share with everybody, it'll say panelists and all attendees. So with that, I am going to find my virtual land acknowledgement. This is this statement is from the College of Family Physicians of Canada with the Indigenous Health Working Group. So we acknowledge that the lands on which we are hosting this meeting include traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are joining us from as we commit ourselves to gaining knowledge, forging new culturally safe relationships, and contributing to reconciliation. So at this point, I'm going to turn this over to Sabrina Wong, who is co-director of the National Coordinating Office and also director for the BC PIHCI site. That's the acronym for our network. So Sabrina, if you want to go ahead and you can start the slides.
Great, so I can unmute myself and try to do this properly. Okay, so I'm going to talk to you today just about some of the work that we've been doing at the Pan-Canadian CIPSIN. So the CIPSIN, first of all, is the Canadian Primary Care Sentinel Surveillance Network. And what we do, Dave and I, as co-directors and leading a bunch of different investigators across the country, is to basically extract electronic medical record data from primary care and do things such as research, surveillance, so communicable and non-communicable disease surveillance, as well as practice improvement. And so I'm not going to talk much about the data source today, but really tell you sort of what we're doing in terms of trying to understand long haul COVID in primary care. Okay, so if we go to the next slide, that would be great. So in the electronic medical record data, there's multiple different places where you might be able to find these kinds of data on COVID. And one place to look is in what we call the lab data. So what we did was we looked in these electronic medical record data to see if we could find anything around COVID-19 lab data. And so here's a bit of numbers showing you what we were able to find with the COVID lab reports. So as sort of as a background, there's about 2 million patients within the CIPSEN data. And so of that, we were able to, with just looking at lab data, find about 83,507 patients. So many less than what is in Canada, but we were surprised to be able to find that many at this point. So this is like going into undeveloped land of the electronic medical records. So these are our attempts to try to understand, first of all, how do we identify people that have had COVID? And then what we want to be able to do is to follow these people over time to understand their health, their primary care needs and service delivery. So that if we go to the next slide, you can sort of see how this kind of breaks down a little bit. So we were able to find some labs, and then of those labs, there were a bunch of people who had greater than one positive lab, and you can see there majority are women, and then there are some men as well. And then of those, you can see that we further broke it down that there was a bunch of people that had 2 or more positive labs, and that 90% had a positive lab that was less than 21 days. So in some ways we had to, like, this is getting a bit technical, but going into trying to figure out, did these people just get repeat labs? And maybe it's the same infection. So you can see there from our data how it's sort of was broken down. So many of the people at that time, there was about 50% in the 19 that were 19 years to 49 years. And we had less people that were, for instance, 65 years and older. So that's our lab data. And then the next place we looked, if we go to the next slide, is we decided to look in this place in the electronic medical records across Canada at health conditions table. And we were able to find that in the health conditions table, another place in the electronic medical record, that there were some COVID-19 diagnoses. And so on the sort of, I guess it would be your right-hand side, you can see it's a little bit of a screenshot there about the diagnosis text that comes in. And so all of these data need to then sort of get categorized into COVID-19. And you can see different ways there in which people are putting in the diagnosis into the health condition. So you can see COVID-19 positive, you could see positive COVID, SARS associated coronavirus. So there's a bunch of different ways that people are putting things into the electronic medical record. So from looking at the health conditions table, we were able to locate an additional 374 people that had COVID-19. So that was the health conditions table. And then if we go to the next slide, you can see the next place that we looked was in the encounter diagnosis. So this is when people come in to see their primary care provider. It's called an encounter, and oftentimes there's a diagnosis that's provided for the reason why they're coming for the encounter. And so you can see here that there was also some text that we were able to look at there to understand the reasons why they were coming in. So not as great as either the lab table or the health conditions table, but there was some additional data there. And then the next slide will show you that the last place that we looked was in the billing table. So this is in mostly fee-for-service practices where you can see where there's been billing for COVID-19. So in that case, you can see there was a bunch of other people that we were able to find. So then what happened on the next slide is that we've come up with a bit of a case definition of who is COVID-19 positive. And so we've been working with our partners on this, the Public Health Agency of Canada. And so inclusion criteria for who's COVID-19 positive is that they would have to have a lab result of positive and or a COVID in the health condition table and or COVID in the encounter diagnosis table. And so we are, this is all sort of preliminary at this point. We're still sort of working on the definition. And if we had our analyst here, she would probably correct me to say that I didn't quite get that case definition right. So we're still working on it. And then you can see, we also want to rule out people that maybe went in because they were concerned about COVID, but actually they're not, they did not have a diagnosis of COVID. So we have some exclusion criteria there as well. Okay, so then the next one is looking at options for a COVID-19 cohort. So of course we want to try to get to understanding a cohort of people who have been positive for COVID-19, and of those in that cohort, we'll be able to understand people that have long haul COVID and have been going to primary care. So we really want to understand the effect of COVID-19 and how it's sort of playing out in primary care, so that we would be able to spread knowledge about the care of people with long haul symptoms. So we're continuing to refine our COVID-19 positive cohort by trying to increase what we can find in the electronic medical record data. So we know that we have to pull out more data from PDFs. So this is important, for instance, in the Manitoba CITSEN, where we can't see any of their labs. And much of the COVID-19 lab data came in only as PDFs. So that's why we have to do some more work there. And we also have to develop other tables that will be useful for examining the effects of long haul COVID. So for example, the exam table and also the referral table. Okay, so some of our very preliminary findings on the next slide will just show you that at the moment our cohort is sitting around 3,000 across the pan-Canadian CITSEN, that most of them are female. And then you can see how the age breakdown is showing up. And most of the cases in our cohort are from Alberta and Ontario, and then it's followed by British Columbia. So once we're able to develop our abilities to extract data from the PDFs, we'll be able to get increase the cohort numbers, and we'll have less holes, I guess I would say, for instance, in the Manitoba data. And then, so that's one of the reasons why we see variation in the number of cases. So not only did cohort or COVID vary by province, but some of this is limited just by our abilities to do what we can with electronic medical record data. And then there's some provincial CITSEN nodes where, for instance, there's a lot of COVID that happened in Quebec, but it's a smaller network, so it just doesn't capture the people. So that's what I have to say about sort of being very nerdy about development of a COVID-19 cohort. So I'll turn
Thanks,
it over
Sabrina.
to Dr. Barber.
So, Dave, do you want to introduce yourself and share your comments?
Of course, yeah. So Dave Barber, I'm a family doc researcher at Queen's University in Kingston and co-chair of SIPSIN along with Dr. Sabrina Wong. So happy to be here. Thanks for inviting me. Just a few things to add on to what Dr. Wong was talking about. I mean, one is, and I'm sure most of you are aware of this, but it's just the importance of primary care data. In following patients, both identifying and following patients who have had COVID and looking how best to describe the post-COVID syndrome. You know, the reality is, I mean, a lot of these patients will never have touched the tertiary care center. So a lot of the data won't be in admin data sets. So if somebody has had COVID and they have, you know, they go into a post-COVID syndrome, you know, all of the symptoms, the signs, will be only be in the primary care record, right? So it's really incumbent upon us to be able to get access to that data to really understand, you know, what's happening, with patients on the front line, and I think that's a really key thing, and that's something that, you know, we continue to work on in terms of extracting chart notes and then using natural language processing. That work has been started, but is absolutely critical because this isn't, you know, the post-COVID is going to be here for you know, quite a while. We need to do everything we can to understand it, and using primary care electronic medical records are frankly the you know, the best and the most comprehensive way. I mean, a lot of the research done so far is, you know, are recruiting patients through telephone calls and that. But, you know, if you really want a big picture understanding what's happening on the ground, it really is in primary care data. And on top of that, you know, I would add in that, you know, the primary care record, you know, isn't just a record of what happens on the front lines with primary care providers. It is also where, you know, it should be all of the information, all the touch points that that patient has in the healthcare system, where it's all aggregated. So there's discharge summaries, or all the labs that have been done, all the X-rays and that. A lot of the stuff, you know, resides in PDFs and that. But you know, that's why we need to move as quickly as possible to extracting the data that's there, so that we can better understand it. Part of this is around linkages as well, and there's certainly a lot of opportunity with linkages to admin data sets. It's and we can do that, and you know, frankly, that would be, that would help, you know, get that gold standard data set for this cohort. And you know, that's something we continue to work with. But I mean, I think there are certain barriers to getting there, but something that we continue to explore. So, you know, all that to say, you know, that, you know, it's a work in progress. We're making great strides at the data that Dr. Wong showed that was from an extraction of December 31st, 2020. And so our next extract just happened at the end of June. So those numbers are going to increase significantly because of what's happened with COVID and our ability to extract and code data. So all that to say, you know, this is messy stuff, but super important. And, you know, even having we don't need to have every patient in Canada, you know, who's had COVID. We just need a large enough sample size so that we can help determine and describe, post-COVID syndrome, with the ultimate goal to help patients. I mean, it's really, you know, quite scary, I would think, to have something like post-COVID syndrome and where we don't have a perfect understanding. And I think that's one of our roles as researchers is to get that understanding so that we can help our patients. I'll stop there.
Thank you, Dave. Okay, so we're zooming through this topic very quickly. I am going to go now to Tim McMurray. Tim, can I ask you to introduce yourself, and then you're going to share some of your thoughts and experiences on this topic?
I guess I could establish a little credibility. So I'm a retired high school teacher, and I was living in Ontario, and I retired as a teacher, and I wanted to get back to my alumni area, which is UBC in Vancouver. So my wife and I moved here, and I needed a new career. as you guys know, the translation of money from Toronto to Vancouver is a little different. So I'm working in long-term care as a maintenance director. I basically, the building, the living room you see behind me is Amicat Edgemont Village, and I basically take care of the entire facility. So it is a residence, but I take care of facilities. So we did go through an outbreak here, which is relevant to this, and it was pretty dramatic. We had deaths, and it was one of the, I think it was the second or third residents that had deaths here in Vancouver. So we were right in the thick of it, and we were involved in it, and I got COVID right away with my partner, and it if anybody want to ask the contributing factors, we'll never really know, but part of it was in the cohorting of floors. We stopped cohorting, and we were mixing all of the garbage into one room. And I'm not a custodian, but we had a lot of deliveries coming in our loading bay. And to give you a perspective of what COVID does, we had garbage piled up in the loading bay to the roof. We had no place to put it. We were, that's because we were putting things in boxes for the residents and giving it to them in their rooms. And then it would come back and get thrown into a room where we did not have adequate facilities set up yet. We just weren't ready for COVID. So the scope of it, consequently in that room, a Cisco truck backed over all the garbage and opened it all up. And in the cleaning, I suspect that in cleaning it up, that's when we received COVID. We didn't have our mask at that time. We just had gloves. We were fitted for our masks, but they were never given to us because, you know, it was for emergencies only at the time. It was in its infancy. So it was a little bit distressing that that happened. So none of us really understood the scope of it. So, and we were sterilizing the floor with Oxivir. So at the time, trying to get it antiseptically clean, I'm sure I was vaporizing the floor with some aerosol. So anyway, that's the background of that. I'm not sure where you want me to go with this, but I wanted you to know that the end result is that I'm part of the VGH post-COVID recovery clinic with Dr. Schwartz. I'm very grateful and positive about this because it's been quite a journey. When you have COVID, I will state two comments, and one is that it's just great to get through it. I'm just so happy to go from where my breathing was, and I get emotional about this because I'm an athlete, so 55, and I work at Grouse Mountain as a snowshoe guide and a corporate adventure tours guy. So I'm quite active, and to have breathing go to something where you're on a Pulmicort nebulizer is something foreign to me. So that was a bit of a journey for me. The second one is that my partner also got it, and it's just an interesting comment that when you're collecting data, that there's a certain measure of pride in some of your patients. They don't want to actually tell you the truth about what's going on with them. So I'm finding, you know, I see signs and symptoms from my partner, not my partner that I work with that received COVID at the same time. And he's very reluctant to say that there's anything wrong with him, although at the time it was quite severe at the time. Mine was a breathing issue. So I had restricted breathing to the point where I had to use the nebulizer. And today I use Pulmicort inhalers on an as-need basis. The steroid over a week's time, I'll use it over a week and then try to get my breathing back. Yeah, so I just wanted to point out that sometimes honesty is part of it. So I'm trying to be, if you have questions for me, I've been through the whole thing and I'm very honest. Sabrina knows that. I like to disclose all I can so that I can help you guys.
Thank you, Tim. Tim, could you describe a little bit the process for the study you're enrolled in? Like how often are you asked information and the types of information?
Right. So it was actually, I actually sought this out. So I signed up. There was some kind of site that we could go on through VGH. Then they contacted me and Dr. Schwartz set up a Zoom call. And then he set up testing post that conversation. So I went in for, you know, your basic VO2 max, all of your breathing exercises. And to check out my lung capacity. I'm not a doctor, so I don't know the technical name for that, but I've had a CT scan on my lungs. I haven't got the, I think my biggest worry is with the CT scan on my lungs is that something's growing in there, because I do suffer. There's no doubt about it. There is residual effects. Like right now, I would say I have a bit of restriction right now. So I'll use my inhaler right now. I won't be to the nebulizer point. But anyway, getting back to the CT scan of my lungs, I also had a number of blood tests. You can see what's in my blood as far as that goes. And yeah, that's what they've done so far. So I guess there's going to be follow-up after that. I don't really know what the pathway is after that.
Tim, can you tell people since when did you have the COVID? Did you say that already?
Sure.
It's in.
So that was 16 months ago. So I got it right at the beginning of COVID in Vancouver area. I was one of the early ones to get it. It's actually quite shocking because you think you're cleaning your hands often, but I believe it was kind of more of an aerosol thing in cleaning the floor. I was power washing in the garage, trying to get all of the contaminants off the floor. I mean, it was a disaster, honestly. And I'm pretty sure that's how it happened, but we'll never really know. But anyway, so 16 months ago, and when I had it, so if you want to, people are asked the typical question, what did you have? I had a fever the first night. I was shocked I had it. I didn't feel that bad, just a fever. And then the breathing started. So I was very fortunate. There's a lot of allergens in Vancouver. So I already had a Pulmicort inhalers for the odd time when I was every time I'm up in the mountains, it agitates my lungs. But nevertheless, I had a Pulmicort nebulizer, which seems to be common in the Vancouver area. And that basically saved my life because my breathing was very shallow. It's still restricted at times. And so I attribute a lot. I really thank my pharmacist for recommending the nebulizer. So, yeah.
Okay, thank you for sharing that, Tim, and I'm sure there will be questions. I will now turn over to Terry Matson, who's joined us, and he's going to talk about his experience. And then Terry, after you finish, we'll be going into open Q&A session. So go ahead.
Okay, sure. Hello, everybody. I'm hoping you can hear me. Yeah, my name is Terry Matson, 39 years old. I live in Saskatoon, Saskatchewan. And yeah, my COVID journey, I guess, began last December. Early December of last year, I was just average day, feeling fine. Went home to make supper that night, and I was, making a normal dish I always make, and I kept adding more and more flavor and spices to it, and just all of a sudden I was like, oh my God, I can't taste anything. And so right at that moment, I knew that I had COVID, because there's no other reason for a person to suddenly lose their smell and taste. So yeah, that it sure surprised me, because I had been feeling, relatively normal. There was no other sign. So I was able to get in for a test more or less immediately when they heard that I lost my smell and taste. So yeah, that was back in December, and I had to isolate for 2 weeks, and it wasn't that bad, to be honest, initially. Just lots of fatigue, strange headaches and muscle aches. Obviously the smell and the taste was the most drastic of symptoms, but yeah, early on, not that bad. My daughter, I have a 5-year-old daughter, she was luckily completely asymptomatic, so that was my primary concern, really, was her health and well-being. But yeah, in the months that followed, my wife unfortunately also had it, and she had all the same symptoms as I did, except for the loss of taste and smell. So yeah, so she kind of recovered a little bit quicker than I did, but here we are 7 months later now, and my smell and taste has barely returned, if at all. Like, I tend to put a number on it, and I'd say I have maybe 10% of my taste and smell, and it's distorted, to say the least. So that's kind of been, yeah, one of the biggest challenges for me has been accepting that. And then along with the smell and taste, I've certainly got some chronic fatigue going, muscle aches. I'm sure it all probably boils down to chronic inflammation. But yeah, a little bit of brain fog and fatigue. And when I'm trying to describe it to people, I typically say I feel like I aged 20 years in 2 weeks. Just the stamina is not there. You know, I was by no means an athlete, but I was relatively athletic, you know, and nowadays I feel like you know, I mow the lawn, I have to stop and take a break to just kind of catch my breath. And luckily no shortness of breath or like any sort of respiratory distress, but just a general fatigue that just has impacted really every aspect of day-to-day life, you know, whether it's parenting or work or whatever. Just yeah, it's tough to accept these physical limitations that have kind of all of a sudden just been dumped on you. So yeah, you know, long story short, it could have been so much worse. I'm so grateful for what didn't happen, you know, with no respiratory distress. My daughter was fine. So, you know, it's been a struggle for sure and tough to accept these things, but I'm trying to just keep some perspective here. And, you know, how many people over the world have died or been in the hospital, or, you know, it just could have been so much worse, I guess. So I'm very grateful for the fact that I'm still here and I'm able to talk to you, and I'm able to still work and to parent and whatnot. So it's certainly been a journey, and it's surreal, to be honest, to say the least. Like, still this far into the pandemic, like accepting the fact that it is here and real, and that I've contracted it, and who knows what the long-term effects might be. There's a certain element of fear of the unknown that creeps in with having had COVID, as I'm sure there is with everybody and all things COVID. There's just so many unknowns there that are it can be pretty scary. So I've had to, you know, maybe consciously take a step back from reading literally every single article about people who have had COVID and what happens or could happen, and just kind of go with the flow, I guess, as it were. So yeah, on one hand, it's frightening in that sense, but maybe Tim can relate. On the other hand, it was like strangely liberating getting COVID early on, just because, again, like everybody, there's so much fear of the unknown. So now, having had it, survived it, and especially my daughter having contracted it with little to no negative impact, has been strangely liberating in that sense. Because I know that with the general public, there's obviously all these fear because they've never had it. But yeah, as awful as it has been and as surreal as it has been, it's strangely been liberating. Just at least like kind of getting it over with, for lack of a better term, has been, yeah, I found is I'm trying to put silver linings on things here, and that's more or less my journey, I guess, you know. Yeah. To summarize.
Thank you, Terry. So I'm going to ask all our panelists to bring their videos back up, and we're going to go to the question and answer session. And I have some questions as well. So the very first one, and this I think is for Sabrina and Dave. They're wondering if gender and ethnicity are being captured or extracted from your cohort study. And being someone that has a focus on gender studies and the fact that we don't often segregate, so this could be a very different, it was interesting that Terry is mentioning his wife and how she experienced this differently. And we don't know if that's just people or if there's something around gender. And Tim, I can't remember, you said your partner did get COVID, right? And did he experience it differently than you?
Oh, yes. Well, first of all, I should say similarly, I should have mentioned, like Terry mentioned, and sorry about my volume, I got my computer cranked, but anyway, I'll get as close as I can. Without scaring you. Okay, so yeah, we lost our sense of taste for about 10 days. It was unnerving. I thought, is this going to come back? It was very surreal. Yeah. So what was your question again?
Did your partner experience it the same way as you?
Right. So that's what I was saying about him. So he lost his a little bit longer than me, but he would So I should mention this to you as well. This interrupts lives quite a bit. So my wife is a nurse, and I was already living in a hotel, as was he, because anyone who had a partner in healthcare, I was really good of my company to send us to a hotel already. So my family wasn't even near me when I contracted this. I was already in a hotel every night. I hadn't seen my family for a couple of weeks, actually, just visits already. They were already preemptively. Anyway, I don't want to digress with that too much. So the partner was with me in the hotel as well. And then as soon as we contracted COVID, we were kicked out of the hotel. So where do we go? That wasn't great. So a friend of ours couldn't use her Airbnb. So she was in Carrisdale, Ontario, Carrisdale, BC, and she volunteered to put us up in Carrisdale. So we were there for 28 days. And during that time, the partner would stare off into the abyss. He would literally blank out and just stare at a wall for at least an hour at a time. It was kind of freaking me out. So, and then a little bit of a state of agitation. But I mean, you can imagine as well, living in an Airbnb away from family, and you know, I'm suffering. He's watching me breathe through a nebulizer, shallow breathing. It's a lot of stress on him too. So I'm sure there was a lot to think about. Nevertheless, he was exhibiting some strange behavior with that. He doesn't really like to talk about it at all. You know, some people have a lot of bravado, and he really just wants to put it behind him and look forward. He does, to me, I'm sure he's fine with talking about this, but he talks about a lot of fatigue. He feels he goes to right after work. We're off at 3 o'clock because we start at 7 a.m. and he goes home and sleeps. So that's not normal for him. He's quite a, well, we play pickleball, but anyway, but he goes home and sleeps. But yeah, so that's what he has.
Yeah, that's amazing. Okay. David or Sabrina, can you tell me about the gender ethnicity extractions that for this cohort?
Yeah, so we do extract gender, ethnicity. Still, it's just too sensitive for us to work on that. The one piece I will add in is that I'm sure that vulnerable populations are affected much more and differently than other populations, and we do because we can link postal codes to deprivation indexes, where we can assign social material deprivation scores to those patients, and I think that that's awfully important work because that's the kind of thing that would lead to to policies that would help target and help those vulnerable patients the most, because they, not having access to the healthcare services that they need. Great.
And I noticed Sabrina mentioned in the chat that you don't have a good measure of gender, and hopefully that's something that can. It's interesting because these are captured from EMRs. So actually, what you'd need is clinicians to be thinking proactively about gender. But given that we can reinforce biases by how we capture data in terms of either underrepresented minorities or gender and sex differences, that would be something important to consider. And I think especially with COVID, because as Terry and Tim said, in a certain way, you've got it, but it's such a mystery for so many people. This is such important work. Okay, so the next few questions actually are sort of all around some of the topics that have come up. We have a question here about what measurement tools will or should be used for tracking patients over time to see if the issues are resolved. I'm interested to hear what you have to say, because both Terry and Tim have mentioned fatigue. And I did a study to see what were the top reasons patients reported for seeing clinicians, and fatigue and pain made those top reasons, but they're really hard to measure objectively. So David or Sabrina, you got anything about that? And Tim, I don't know in your study if they're asking you about that. So I'll ask Dave and Sabrina to answer first.
So, I mean, ours is a pan-Canadian network, right? Where we extract data out of 17 to 20 electronic medical records. So we're doing a little bit of deeper dive with some of the networks and some of the electronic medical record vendors to see if we can get at some of this stuff that isn't super easy to extract out with structured data. So as an example, Dr. Barber's network in Kingston, they actually have the ability to look at the clinical chart notes in their particular network. So we're developing, I don't know, I guess artificial intelligence or natural language processing in some parts of the network to see if we can try to capture some of this. The other thing that we're trying to do, and I have been trying to work with the clinics that Tim is going to, and that is to bring them into the Citizen network, because I am sure there's a huge battery of tests that people are doing, both clinical tests, but also the self-reported experience measures like on fatigue and that kind of thing. Because I don't know if those are like, so Tim, you said your partner, he goes home and sleeps. He's not like he's going to see the doctor about it. So he's just trying to manage it himself. So some of this stuff is going to take other kinds of data collection, not just electronic medical records. But our hope is with a cohort, we would actually then find ways to be able to contact people and then ask them more in-depth questions, because we know that the EMR data, or even if it's linked, isn't going to capture some of the things that Tim and Terry have been talking about.
Yeah, I think it's a good point, Jillian, of just about the pain fatigue. I mean, we don't, for the Citizen data, I mean, it's hard to extract, you know, like scales for, you know, fatigue and pain from the EMR. I mean, I think, you know, the value of, you know, Citizen would be, in that case, would be connecting to, you know, the practice-based researchers and maybe recruiting patients who are COVID positive, and having surveys done with those patients in terms of scoring for pain and fatigue. I mean, the other piece is to look at, we often use proxies as an example. You know, if in the chart notes, if a patient's fatigue, you could, if they're missing, if they've had to miss work, if there's notes to take off work, or they've, you know, had a lot of workup, you know, looking for a reason for the fatigue, that would give you kind of a proxy for how severe the fatigue might be. You know, and then of course other medications. I think the impact, you know, both of those on mental health is significant as well. So looking at medications, you know, is an important piece in that data that we have as well.
So Tim, is this something they're asking you about regularly in this study you're participating in?
No, this was, I believe, it's sort of, the ball is in their court. They're just going to contact me whenever. They didn't give any indication. Actually, they didn't even give me a result of my CT scan. So I believe it was sent to my physician. I need to meet with her and go over that. That wasn't that long ago. So I'm not being remiss with that, but no other results at all were reported to me, and they haven't given me any indication of any follow-up that's going to happen. So I guess I'm a willing participant. So whenever they want to get on it, that's fine.
I know exactly what you mean. I've actually participated in 2 COVID studies. One was before I was vaccinated. They checked for antibodies, and I was actually at that point happy to see I didn't have it, which means I didn't get COVID. And now post-vaccination, they're looking at how long the antibodies are in. So I had my first blood test, and I'm also don't know the results. So hopefully we'll hear more about that. So it's interesting. Sabrina made an excellent point, and I'm going to jump in the questions. I'm going to come back. There's some about rehab and physiotherapy, but she made an interesting point that, you know, if you're not seeing a doctor because you're managing, right? Like, what can a doctor do for fatigue? There's no medication to take for fatigue, short of an adrenaline shot, and I'm pretty sure that's not clinically indicated or recommended. But so a lot of people are self-managing: headaches, fatigue, pain, brain fog. So where and how is this getting captured so we understand the magnitude of the impact? Terry, I was slightly horrified, but struck by your comment that you felt like you aged 20 years in 2 weeks. And that is like, that's such a contrast. You know the difference between your pre-functioning and post-functioning, but those are things that are very difficult to capture in EMRs. Okay, so there is what a participant asked if there are mental health impacts being evaluated alongside physical impacts. So it was really interesting what Tim was saying, because she mentions here thinking of anger, anxiety, depression associated with this. Mental health is another big thing in primary care, very difficult to treat, not something we're excelling at. And if this is then resulting in an increase, you know, there's the effects of the actual pandemic itself and the isolation and everything else and all the worry and stress Terry was mentioning. But then if you actually have things happening after as a sequela from COVID, you know, are those being captured? So again, I'll open it up to the panelists to discuss that. Then I'm going to come back to our physiotherapy questions. Dave and Sabrina, you're on first.
Go ahead, Sabrina.
Okay, sure. So we can capture things like depression and anxiety. Yeah, but again, it's dependent on whether or not the person comes in. So it's interesting, right? Stephanie, you mentioned unattached patients. In fact, these are people who are attached to family physicians, but they're not going in because they might be like staring off into space or taking naps more or having a bit of brain fog moments. So I think I think it brings up a really good point around how do you capture that. And we're actually looking at partnering with another system. It's called the Canadian, oh God, I'm going to get it wrong, CPIN. So Canadian Practice Improvement Network. Anyways, if someone's on there, they can correct me because I'm pretty sure I said that wrong. But that is run with Dr. Bill Hogg and Dr. Sharon Johnston, where there's an ability to work to measure patient-reported experiences and outcomes, and then attach that to the electronic medical record so that it's a little bit more regular. And then also your family physician would be able to see that and they might be able to help with resources or, you know, your primary care network. So, yeah, I mean, I think, you know, what I think Tim and Terry have pointed out is that the healthcare system is barely scratching the surface in terms of what people need to actually make it through on a week by week basis, because some of this isn't necessarily, quote, medical care, even for primary care. It's much more about how do you manage. And as both of you, Terry and Tim, have said, your lives have kind of changed a bit, right? So you're kind of doing stuff that you were doing, but you definitely notice a decrease in sort of how you'd like to be in terms of your functioning and quality of life. So I think that's a really hard shift. And I don't know, doctor, no nurse, no one's going to help, no healthcare professional. There's no pill for that, right? There's no prescription. So I think those are really important points that you guys make.
I think just to add on, I mean, you know, going back to the sort of mental health piece, I mean, certainly, you know, that data, we have pretty good data. We have algorithms to identify, you know, those conditions. And, you know, part of that is looking at the medications in terms of, you know, antidepressants and anxiolytics as well. I'll bring up, you know, as a frontline clinician, I think I would be most concerned that like when you have patients, if you just sort of, you know, if a patient's post-COVID and they have fatigue, you know, my concern is that we just say, well, that's fatigue is from your COVID because you had COVID, right? And not doing, you know, a workup for that fatigue, because this is how we miss conditions, right? So let's just say that person was going to develop like hypothyroidism and they developed that, but, you know, every time they came in and said they were tired, we say, oh, well, you have post-COVID. So we need some sort of guidelines, you know, as to what should be done for these patients. I mean, this is the importance of identifying those COVID patients within your practice and making sure that, you know, that they're being seen, if that means calling them in and doing these screenings for different things. I think that's also important.
And that leads, that sort of leads to the next question. And that's really, it's really important, Dave, because one of the other things is there's having, I got tuberculosis, not TB, typhoid, international travel. That was fun. Typhoid at a very young age. I got it at 25, and I got photophobia and migraines with it. And when I went to see the clinicians, they're like, well, you'll just have to live with it. And I'm like, I'm 25. I can't like start avoiding light and life for the rest of my life. So I think this notion of what can we do to help people, not just that they have to get through it somehow on their own. So we do have a question about whether any evidence that rehab data is being captured. And Joni Cranston, who's one of our patient partners from Newfoundland, who's also a physio, or I'm going to get the wrong term, but she does physiotherapy. She's asking if for both Tim and Terry, was there any, were you offered to see, or have you seen a respiratory therapist and helping with breathing exercise? So 2 questions. Any way to capture whether any rehab is being done? And second, is any rehab being done? And Terry and Tim, do you have any experience with that?
Me personally, unfortunately, no experience. Luckily, like respiratory issues weren't my thing, so I never really sought it out either. But nothing yet. Like I understand the whole COVID thing is still so very fluid, but yeah, nothing on my end yet.
And Tim, because you said that was more a thing for you, and Joni's wondering if you were offered breathing exercises, and you know, whether there was any difference between breathing through your mouth or nose. So really specifically was around the breathing issue.
Yeah, so I'll try not to speak to it at length. It's a teacher thing, but anyway, I wrote 3 things down. One is the anger issue, the anxiety issue, and the depression issue. As far as anger and anxiety goes, so I'll speak to anxiety. So we've had to actually anger, and that is that, and this is for all healthcare professionals, I've had to wear a mask through this. So I walk in at 7 a.m. and I have to wear it till 3 p.m. That's been incredibly challenging, because even going up 2 flights of stairs is, I feel 80 years old. And I know Terry touched on that. You just feel like an old person. So what's weird about it is that, and Sabrina knows me well with longevity, with doing intense stuff. But if I break through the barrier, if I'm going up a mountain, it takes me about a half an hour. If I'm going to Garibaldi and I'm hiking up a steep grade, it takes a half an hour. I feel horrible. After that half an hour period, I can go forever. There's just this clearing, and I feel like $1,000,000. So I can't explain that, but I need to break through a barrier in working out. It's the same as something simple like pickleball. I'll be walking with my wife on, you know, in front of the ocean on a flat surface, and it takes me a half an hour to get going. And then once I'm going, I'm back to normal. So that's a very anxious feeling to have to get going with that. So I break through the barrier of that by doing longer things. Yeah, so getting back to the masks, yeah, I'm not wearing it today. BGH just announced that we can take them off. So we're celebrating right now. It's the first time in 17 months. It's honestly, everyone here, COVID and non-COVID, talk about shallow breathing. So I think it was Joan asked the question, do I breathe through my mouth? Yeah, we breathe through our mouth all the time, because you can't breathe through your nose through a mask. So I've conditioned myself to breathe through my mouth all the time, and and shallow breaths. So all of us are practicing right now, self-practicing. Everyone's reminding yourself, breathe deeply, because you can. I don't know, it's just a condition. When you have the mask on all day, you start to shallow breathe. That's what many colleagues have talked about that. So yeah, as far as depression goes, I must say though, on a humorous note, I live in BC, not Ontario, so I don't think I could be depressed here, but anyway.
Okay, and so were you referred to any physiotherapy, Tim? And then I'm gonna ask David and Sabrina to comment on if there's any way to capture that in SIPSIN.
No, not at all.
Okay, Dave?
Yeah, I mean, that's difficult to capture. I mean, this is some of the work we're doing, looking at the chart notes, and it might be there. I mean, I think honestly, the best way to capture, physio and rehab would be to recruit, patients into a study, and getting the prems and proms, getting, the information directly from the patient about that. That's probably the best way to do it, because it's hard, because we don't, as an example, in Ontario, patients don't need a referral to a physiotherapist. They can just go, right? And so it's, even in admin data, it would be hard to capture that stuff. So I think you need to recruit patients for that.
Yeah, we actually had a postdoc working in the Spore Picken who was a physiotherapist and really pointed out the gaps between, the community-based services of physiotherapy, and how, like, basically there's almost no integration, I guess, between primary care and physiotherapy. It's really kind of left up to the patient as to whether or not they kind of go or not.
Yeah, that's interesting, because for me, I would think that primary care is that, as well as the care provided in family medicine. But you're right, there's a big disconnect. And unfortunately, one of the things with COVID, there's a lot of talk about equity and vulnerable populations and disadvantaged populations. Obviously, physiotherapy then becomes an out-of-pocket expense. And if you're, that means that you're paying for a system where you get the care you can afford. And if there's ongoing health, like lung issues, that's a bit of an unfortunate situation. So, okay. Juliet's very interested in SIPSIN data. So she asked if the EMR shows referrals to other providers, respirologists, occupational therapists. It does show referrals, yeah, but it would be hard to capture who exactly. It could be to a clinic, it could be to something. So it's a little harder to capture, I think, what those referrals are for, if I'm correct about that. So
well,
I'm going to get to our...
And then you go to places like Dr. Adira Levin has set up these post-COVID clinics across, mostly in British Columbia, but I think there's also one in, there's some in other provinces. So it's this post-COVID clinics that are actually not attached to primary care. So for instance, Tim is in one, and I don't think his family doctor probably knows what's going on in that clinic, because it's a different clinic. So anyways, it just goes to show you that we need to do a little bit more work in terms of the integration, and we can do integration, but it's going to take both the systems behind as well as people actually working together in the system.
Okay, so we're going to do we're going to end a bit early today. We typically, because you got through the other portion quickly. So the last question is, and Simon, I would ask you to please post the link to your paper in the chat for everybody, because not everybody can see the Q&A. And I realize that Kent has a hand up. Kent, are you able to post in the Q&A? Sorry, my dog is going crazy. And so I will get to Kent. But the question I'd like our panelists to round up is, where do you think the research priorities need to be? So you've mentioned a lot of things that are being extracted, are being tracked. Terry and Tim have mentioned things that are they've experienced that aren't being extracted. So thoughts on what we need, what are the answers we need, so then we can figure out the questions. What do you think we don't know right now that we need to answer? And I'm going to put Dave on the spot first, and then Sabrina, then Terry, then Tim, and then we'll see if we can open Kent's microphone.
Yeah, I mean, so I would be quite concerned about the vulnerable population. I mean, it's like they've been hit more hard than any other group, and and it just there needs to be research done on to how that population can be identified and helped. Like what kind of services, what kind of programs need, and where do they need to be in order to get those patients the help that they need. I think the other big piece is mental health, right? I mean, like the mental health piece is huge to this, and I don't think we have a good grasp on how significant that is, and what needs to be put in place to help those patients. I mean, I think I can speak from working in Kingston, Ontario. I mean, the mental health services were stretched, before COVID, and now it just is going to get worse. And so we need to figure that out, and what kind of resources need to be put into helping those patients, identifying patients, and what kind of help they need in regards to mental health, depression, anxiety, and so on.
Thanks. Sabrina?
Yeah, so I mean, I think, from my perspective, sort of a health services researcher and clinician, it's really trying to understand what the need is and where is their unmet need from patients' point of view. So really taking sort of like 18 months or 16 months, whatever Tim had said that has gone on, and also for Terry. I mean, it's a big deal. So really trying to understand how can we make the system better so that it helps get to unmet needs for patients. So that's what I would like to see. And I think also the information system. So we can't just be looking at electronic medical record data, but the combination of patient-reported experience and outcome measures with the electronic medical record, because looking at hospitalizations, that's important, but it's really these quality of life issues. And then we see things like the fatigue and the inflammation and pain, which are well managed in the community, but we need to be able to understand the burden of these things.
Yeah, and help mitigate that burden. Terry, any ideas?
Well, I would certainly echo what Sabrina and Dr. Barber had to say there, just in regards to mental health support. That's clearly, like, resources were already stretched pretty thin in my province as well. And now COVID has just kind of thrown a bomb on everything in terms of mental health and then the resources available. So I certainly feel like there should be an emphasis on, of course, like post-COVID support groups or something. I feel personally that's something where I've longed for almost. I wish that was readily available, just to simply talk with others who experience the same thing as I have. It would be interesting to see too, and I don't know how realistic it is, if there's any sort of like genetic predisposition that people may hold that's going to, obviously this is something that would take a long time to figure out, but it clearly affects a cross section of the public greater than others. And I know that socioeconomic status obviously plays a part into all that, but there does seem to be like, seemingly there's a genetic predisposition that some people may have. It would be nice to see if more research could go into that, and try to figure out which groups are really the most at risk. And maybe that's wishful thinking, but that seems like that would be beneficial in the long run. Research stuff like that.
I think that'll be super important for development of ongoing vaccines, because now with the Delta variant and vaccinations and vaccine hesitancy, we are seeing different age demographic this condition than you'd expect. I mean, you and Tim are both good examples of this. You see this in the flu has always been more of a risk for older people, right? For people over the age of 65, and that's not how this virus is acting. And as it mutates, I have a feeling it's not going to get better. So, we do have a final question, and it does involve vaccination. But Tim, do you want to go ahead and talk about what you would like to see dealt with in research?
Yeah, no, I'm mostly with anxiety. I don't know if Terry feels this way, but like right now I'm a bit anxious with the breathing. So it's how to deal with the the psychology of not feeling like, here we go again, it's coming back, So it's the residual psychosocial part of your, you're just trying to work through. Don't get stressed about it. If you can't breathe, just take your Pulmicort, So I don't know where this is going. My biggest, I think my wife is a nurse, so her biggest concern is anything growing in my lungs? Is there anything in my lungs? That's what I think about, and I'm trying to not think about it. But why do I have this breathing issue, this persistent? And it's not predictable. It's just certain times. And some people might think, well, you have allergies. No, this is not allergies. This is completely different. Yeah, I've never had allergies in my life. So we're going from someone who has nothing to something that greatly affects my ability to breathe. So from that aspect, I'd like to know, is there going to be a long-term something growing still? Like, is it gone? Even though they say I'm immune, I've had my 2 shots. I also have high immunity levels. So, but I still have this. So anyway, that's the only comment I have.
Yeah. I think having a parent that has several respiratory conditions, I think like that whole thing that when you start to feel your air go, controlling the anxiety, that's you can have all the rational arguments in the world. There is nothing as terrified as feeling like you're running out of air. So I'm not sure how you get around that hindbrain issue, but the issue is if there's damage to the lungs and is it progressive, is it degenerative? I think that is going to be a really urgent research question, because then you need to start getting interventions to stop or heal that. So our last question, you mentioned, Tim, that you were double vaccinated. So Kent, who's one of our patient partners from BC, is wondering if after the vaccination you noticed any symptom improvement. And Sabrina and Dave, this is another disconnect, right? The vaccinations are not necessarily administered by family docs, and there doesn't seem to be a coherent record of a way to these are being recorded and tracked. So is it self-reporting for vaccine? How are you getting the vaccination information into your cohort? So Tim first, and Terry, I don't know if you have anything to say about that, but Tim, after what was your experience after your vaccination?
No, I mean, it's the exact same fever again as I had when I had COVID. And no, there's no improvement. There's just more anxiety that every time I have to do this. And I know as a healthcare worker now, I'm going to have to go through this every year. And most of us as Canadians will have to go through that. I guess the world. But anyway, no, it's the anxiety of it, because there's no improvement. It's just having to go through a fever every single time. So that's about all I have to say.
Yeah, I think all of us were a little bit like, how are we going to react, and what it's going to be like. And one of the things about the vaccine that I think also needs to be taken into account, those of us who are privileged enough to be like, well, I'll just assume I'm going to feel like crap for 2 days. There's a lot of people that can't afford 2 days off work, right? So there is a lot of anxiety around that. Terry, anything to add to that?
Well, for me, so prior to receiving, of course, yeah, I haven't fully vaccinated, and I had, certainly read anecdotal evidence of people like myself who had, some symptoms, and they had subsided magically after their first or second shot. So I certainly made the mistake of having some expectations, and unfortunately, I felt like after the first shot, at least the taste and smell had actually regressed. I was feeling like, I remember the week or 2 leading up to my first shot, that maybe it was starting to improve a little bit in the taste and smell world. And then, it was honestly like probably an hour after I had a shot, I was having the weirdest, I was at work here, and I remember being like, does anybody else smell cigarettes? Like, I could smell cigarettes, and nobody could smell them. And like, it was the weirdest thing, which has happened a couple times since. But anyway, I feel like, no, the shots were wonderful and everything going forward, but they actually, it didn't help with the long symptoms like I had foolishly thought they would. And if anything, I felt a slight regression in at least the taste and the smell department. So yeah, sad to report that no real improvement of those symptoms, unfortunately. But
yeah, that is unfortunate. That would have been a nice thing, other than because there's some evidence that people who've had COVID do have a greater immune system reaction to the vaccination. So Sabrina and Dave, how is the vaccination information being captured?
Yeah, so I just want to go back to what Tim was talking about, and just like the impact of, the respiratory issues that Tim's having, really quite significant, and I think that's important to look at, and how that's, the impact of that on the healthcare system and to the patients personally. I mean, the example, I hope that Tim's seen a respirologist to investigate his symptoms, and has that referral in place. But that's it's a stretched system to begin with, right? We just need to make sure those resources are there. And certainly glad he's had a CAT scan. For the vaccinations, Canada, every province does their own thing. It's very difficult. In Ontario specifically, there's the vaccinations are given in multiple places. Some pharmacies are good about sending the information, and it can be inputted. It's faxed to us, and it's inputted into the preventions area in the EMR. I think hopefully that the government's developed a better system that can be sent automatically, and because we need to understand which of our patients have been vaccinated, and frankly, the ones that haven't been vaccinated, it's going to fall on primary care providers to get that last little bit. So that information, it's going to exist in the EMR, and it's going to be important to follow along also post-vaccination reactions and possible complications and that. So we continue to work on that piece.
Yeah, I was a bit surprised because I was vaccinated in the US, and it was voluntary, but you could sign up. It was VSafe, and it was run by the CDC, and they checked in with you every day for the 2 weeks following the vaccine, and then up at certain times. And I still get like every, I think 3 months now, they're like, okay, have you had anything? Have you had any of these? And so that's done across the country. Every site that does vaccines, access to that. And I was a bit surprised when my parents were getting their vaccination here that there was nothing. There was nothing for them to sign up for to systematically track that. So Sabrina, thoughts on that?
Not any more than what Dave has said. Yeah.
This is I guess establishing the research priorities. Like, there's so many unanswered questions about this, and I think that I just want to wrap up here and thank everybody for participating. Terry and Tim, really appreciating your perspective. I think that one of the things that will be important, Terry, you mentioned it, I think a lot of people are feeling a sense of isolation. And when you're getting all these things, you wonder, like, am I imagining this? Because you're in uncharted territory and we haven't accumulated the evidence. You never know. And in some ways, it's a little bit like cancer survivorship. Like, once somebody's had a cancer diagnosis, and even if remission, you wonder about every single symptom, right? And it comes back to Dave's point, like, will we just dismiss this as being part of COVID and miss other conditions? And how will, your health be in the future? So I really appreciate your willingness to participate in this seminar. I hope that you've motivated some of our research community to get onto some of these questions and be asking them in a meaningful way. And I hope that we can provide evidence that will make your lives better. And this is why we're supported by the Canadian Institutes of Health Research, a strategy for patient-oriented research, because this is what's important to you. Our research should be oriented to helping make your life better after having endured this very scary illness and the ongoing uncertainty to support that. So thank you to all of our attendees. There will be a survey sent out. This was our last seminar for this academic year. We will probably start up again in the fall. I hope we have an update with some results on terms of all the work that's being done to help improve the health and lives of people who are touched by primary care in Canada. And so thank you. There will be a recording of this podcast available if you'd like to recommend it to colleagues or friends or family. on our website. Nick will post the website in the chat shortly, and we will be sending you a survey afterwards. If you could complete it, let us know what you think and any ideas for future seminars. So Terry and Tim, thank you so much. That was, once again, I learned something new in every one of these series, and certainly your perspectives were helped add depth and nuance to the research work that's going on, and hopefully also help people think about ways that we need to move ahead in this area. So thank you, everybody. Have a wonderful afternoon. Stay safe and be well.
Bye.